Malignant hyperthermia develops shortly after the onset of the anesthetic halothane or succinylcholine. Temperature exceeds 104 F. Metabolic acidosis and hypercalcemia also occur. A family history may exist. Treat with 4-dantrolene, 100 oxygen, correction of the acidosis, and cooling blankets. Watch for development of myoglobinuria. Bacteremia is seen within 30–45 minutes of invasive procedures. Instrumentation of the urinary tract is a classic example, and there are chills and temperature spike to or exceeding 104 F. Do blood cultures ×3, and start empiric antibiotics. Although rare, severe wound pain and very high fever within hours of surgery should alert you to the possibility of gas gangrene in the surgical wound. Postoperative PO fever in the usual range 101–103 F is caused sequentially in time by atelectasis, pneumonia, urinary tract infection, deep venous thrombophlebitis, wound infection, or deep abscesses. Atelectasis is the most common source of post-op fever on the first PO day. Rule out the other causes listed above. Listen to the lungs. Do chest X-ray. Improve ventilation, deep breathing and coughing, postural drainage, incentive spirometry. The ultimate therapy if needed is bronchoscopy. Pneumonia will happen in about 3 days if atelectasis is not resolved. Fever will persist. Chest X-ray will show infiltrates. Do sputum cultures. Treat with appropriate antibiotics. Urinary tract infection typically produces fever starting on PO day 3. Work up with urinalysis. Urinary cultures. Treat with appropriate antibiotics. Deep thrombophlebitis typically produces fever starting on PO day 5 or thereabouts. Doppler studies of deep leg and pelvic veins is the best diagnostic modality. Physical exam is worthless. Anticoagulate with heparin, transitioning later to warfarin. Wound infection typically begins to produce fever on PO day 7. Physical exam will show erythema, warmth, and tenderness. Treat with antibiotics if there is only cellulitis. Open and drain the wound if an abscess is present. When these two cannot be easily distinguished clinically, sonogram is diagnostic. Deep abscesses like subphrenic, pelvic, or subhepatic start producing fever around PO days 10–15. CT scan of the appropriate body cavity is diagnostic. Percutaneous radiologically guided drainage is therapeutic.